Zo, Engels, Nederlands? English. Well, first of all, thanks for your patience. A little startup issues. Ooh, does this work or should I remove this? Can do this, right? All right. And today, can everybody online hear me? That's the first question. No response. Yeah, I just clicked them away. All right, great. Then we continue. So my name is Martijn Bruin, although I just Daniel Martijn Bruin. That's the full name my mother gave me, but for you guys, I'm Martijn. And when you get really pissed off at me, he calls me sometimes Daniel. I work together with Dirk on optical technologies that we develop, that we research, and we want to bring into the clinic. And today I'm going to talk to you about optical coherence tomography and how we apply that in the clinic in several specialties. So first of all, I would like to give you an idea on what happens when a patient enters the clinic. Of course, you have been to your primary physician, huisarts, and the primary physician gives you a relocation or transfer to a hospital if something serious is suspected. And what basically always happens is when you're a patient, you come in for a first consult at the outpatient clinic and you meet a medical doctor and he's asking you questions. And they can also, if they suspect something, start up a complete, what we call a workup or management of a disease. And usually this starts with asking if there is some additional imaging needed. Definitely in an oncological environment where you want to find out if something grows inside the human body, for example, something you don't want. And this diagnostic imaging technology could be CT, could be MRI, but most of the time it is endoscopy. Endoscopy is one of the broadest used imaging technologies in the clinic. And then they go inside the human body with an endoscope, look around, and which is a tiny tube with a camera mounted on top of it, and you can look around. Fortunately, within this tube with the camera, there's also what we call a work channel. So you can bring down tools through the work channel to actually execute some work if that needs to be done. And one of the most frequent things that needs to happen is taking of a biopsy. Anybody understands what that is? A biopsy, it's a little piece of tissue that you take out of the human body and you can give that to the pathologist. And pathologists can study that, try to understand how aggressive a lesion might be, or how far the depth of growth is into surrounding tissues. So they have to do biopsy analysis. And then all the answers come together, which we call in a multidisciplinary meeting, where the specialist is, the pathologist is there, radiologist can be there, and a treatment can be decided in a group. And after treatment, you usually get treatment follow-up. The weird thing about this is that it happens in several locations in a hospital, separated also usually by time, and with different specialists. And as a result, this can be rather time-consuming. And because it's rather time-consuming, up to sometimes 6 weeks, it's an expensive endeavor. But it's also not so nice for the patient, because they are in this waiting mode, waiting for an answer before they know what's actually going on. So one of the goals that we actually have, and things we really want to do with fast and optical imaging techniques, is see if we can speed this up, preferably in one location in one moment in time, even including the treatment. And I usually like to give an example on that. And that's an example on renal cancer. I also work at the Department of Urology, so it's not crazy that you will see a lot of urology-related examples today. But renal cancer is something that a patient is usually confronted with because they pee a little bit of blood that ends up in the urine, and you see that happening, and you think, oh, what's going on? I need to go to a doctor and eventually to a hospital. Okay. So sometimes it just disappears, but most of the time it doesn't. I'm not sure what's happening here, but it's yeah, I guess. Ja, hij zit er goed in. Powerkabel ook. Hij is er weer. Well, yeah, I cannot change the cable, I guess. It's working now.
Sorry.
Yep.
Few chat messages. Might be some people who are complaining who can't follow the slide very well. Okay.
Oh no. It's affirmative. A double yes. That's always good. So what happens basically is that the urologist, that's the specialist here that treats those kind of issues, said, okay, let's do an MRI or a CT scan with some contrast. And what happens then, you get a cross-sectional image of the abdomen that's at this location, the belly. And what you see here is a lot, but you see two kidneys. That's good, you have two, which is, that's a nice thing. But you can also see within the kidneys, there's this growth, which is abnormal. And well, this can give the urologist reason to perform actually a biopsy, because basically two things can happen. It's either a benign growth or a malignant growth, and the latter really needs to be addressed, of course. That is something that we actually really want to do. The idea is that we can do that with optical technologies. And what do we mean with optical technologies? We have a whole range of these things. But the treatment itself is usually surgery. So you come to the operating theater, the surgeon can perform surgery. They can do actually three things during surgery. One is complete removal of the kidney. You have two anyway, so why not take one out? And that was always the mojo basically back in the days. When in doubt, whip it out. However, they found out after years of doing this that patients that are left with one kidney have actually later in life a lot of cardio-related comorbidities. So heart problems, whatever, all that stuff. So they decided, okay, let's not do that anymore. Let's just take the tumor out. So you can do that by what we call a partial resection. You cut out a part of the kidney and you leave one part of the kidney intact there, or a very, very local resection, and you just scoop out the tumor with tiny margins. However, and that's beautiful and that works really well, but it's still quite an invasive surgery. It's in the abdomen. We use beautiful robots to make anything as minimal invasive as possible. However, that's still rather invasive. You're out for 6 weeks. Things can still go wrong. It's a full narcosis. Narcosis, yeah. Not really, yeah. But anyway, that's what you have. That comes with issues, and we have been working on novel technologies actually to treat it, and we call it focal therapy. And what you basically do is you bring in the patient in a operating environment. You place the patient on its side. What happens then is the kidney is pushed against the skin, and you can bring in needles through the skin into the tumor. And then you can basically do several things. The needles there. You can start freezing the tumor and make it ice cold and cells die. Or you can heat it and you burn it away. We have lasers to burn it away. That's an indirect, what we call hyperthermal shock to the tumor. There are a whole range of things we can do with tools like that, which is quite nice, minimally invasive. And for example, if we do a laser treatment, you can be done in 10 minutes. Amazing. So that's something we can do. You want to see an example of that? This is with the cryoprobe. So what you see here is a kidney tumor where we bring in a needle. And in this case, it needs to be a little bit extra positioned with an extra tool there, but you really bring it into that, well, growth. And when you're done, you can have 5 of these needles and start freezing a tumor. You see some temperature probes there in the middle, the gray ones. We monitor the temperature. Yes.
I have a question because you said the patient was lying on his side.
Yeah.
And then the kidney
is slightly pushed against the skin. Yeah.
Yes, but on the bottom side or the upper side. So if you're lying on your left side,
Yes.
you're being operated on your right side.
If you're lying on your left side, this kidney is usually pushed against the skin here.
Okay.
Yeah. And we can end up with a snow cone or snowball like that. Actually, the killing here is done by thawing, not by freezing, because during thawing you get all the ice crystal formation, and that's really what breaks up the cells, and you get all necrosis over there. And we repeat this cycle a couple of times, and then usually it's done.
Very cool.
Very cool. Hey, however, so this is what we can do. In 10 minutes, 30 minutes, you're done with the treatment. But you still have to wait for about 6 weeks before you get this treatment. So what we actually need is really speed up this diagnostic process in order to make sure that the patient is qualified for this. So you will have what we call a one-stop shop, right? And with normal biopsy, harvesting and analysis, that's very time consuming, right? You have to create those microscopic slices. It needs to be processed, it needs to be stained, it needs to be dried, it needs to be put on a glass, then the pathologist needs to take a look at it. That's a time consuming process. And optical technologies actually can really play a role there. If you have a technology, any optical technology, that is real time and gives you the diagnosis right away, you're basically in business. Because then, if you know what it is, you can discuss with the patient, like, okay, we already brought in some needles with an optical technology. We're already there. This is what we believe that you have with a certainty of this high, and we can treat it right away. Are you okay with that? And we know by now that a lot of patients would like that. However, you need that technology. And optical coherence tomography is an excellent candidate for that. You have some theory background on OCT, that's what I understood. So you know everything about interferometry and light scattering, and basically how we build up an image with OCT. I'm not sure if they're going to show pictures like that, but back in the days when they started this in a long time ago, yeah, the setup looked like this. Big table, optical table, about 2-3 meters length, 2 meters width. It was on air, so vibration damped with big lasers on it, a lot of optical components. And that's an OCT system where we did measurements. I said there, but I was there too, so back in the days. And I remember very well that also back in the days, clinicians came to us, they knew about the technology and how we were making excellent images with a very slow frequency, let's say, I think a minute per image or something like in that ballpark. But they asked, can you make this a system that's clinically viable so that you can bring to the patient? And we don't say no, Dirk never says no. And this is what was created. Just we reduced the size on the optical table, little card, still all the optical components there, the laser, everything. And we were allowed to do that back in the days, to bring this into the clinic and do measurements there. You can hardly believe it anymore right now with all the regulations that's out there. But back in the days, this is what we did. And it helped us. I think we used it in ophthalmology, but also a little bit in some onco-related questions, research questions we had back then. But the setup itself really scared the patient that much that was always the question if they would come back to the hospital. Luckily, nowadays we have systems like that. So what you see here is a typical OCT system that's been used in ophthalmology, where you can sit as a patient, put your head in a headrest, and they scan the front or the back of the eye, the retina or the cornea. And that allows ophthalmologists to say something about pathology that goes on over there. We have systems like this one, and I will show you the details later, that we use in endoscopes because it has a very tiny catheter. You can interface this catheter with the system. It has optical technology in the tip, and we can image tissue. And we have things for more outside the human body on a card with a handheld scanner. But it all started with big open air setups. Just to give you an idea on what type of data we actually acquire in dermatology and ophthalmology. So with this system, you can see that we can take cross-sectional images of the skin with very high resolution. Systems like this go down to about 15 microns or 10 microns and give a very detailed, at least the architecture of tissue. And ophthalmology, we have on the back of the back part of the eye. Cross sections like that, where we really have a full anatomy of the retina, all the layers there, and even down to what we call the blood supply of the retina, the choroid. And you can imagine that these are really big applications for OCT in the clinic, because these images were not able. Physicians did not have the option to create those type of images before, and now they do. Just to give you a little bit idea that this is, again, our big setup for a handheld scanner. We can also interface with some kind of a microscope setup. But what we also have are very tiny catheters. And this is an example of that. These tiny catheters, they basically work like a lighthouse. They rotate. Because on the tip, they have like a little mirror under 45 degrees. And as a result, we have a 90 degrees reflection of laser light. And if you rotate the whole system, you basically build up an image around that probe. And we can also pull it back through, for example, a tube, like an artery or any tube, the esophagus. And you build up a three-dimensional image of the tissue. It's usually a little bit faster and smaller than a normal lighthouse. But this is how it basically looks like. Again, the OCT system itself, but this is the catheter that you interface with it. It had actually a liquid supply, so we can bring down fluids at the region of interest where we bring down the whole catheter, which is actually quite nice because we do this in the coronary arteries and there's blood. Maybe you already know that by now, that light and blood is always a tricky interaction, but usually we cannot really look through blood with, in this case, 1300 nanometers of light. It scatters away, it's absorbed partially, it does all sorts of things, but looking through blood is an issue. So we flush the blood away when we do the imaging. And we can do that from a system that's built in. But in the tip, you have something like this transparent part, where we do a pullback over 5 centimeters to create that image. And it's quite nice. Here you see an example of how that actually works. You see the probe here. The probe is 0.9 millimeter in diameter. It's quite small, so that means you can bring it down through almost any work channel of any endoscope. And it creates pullback just by rotation. But you still need access to the human body. And we have several ways of doing that. A little bit more invasive is the use of trocars. A trocar is basically a round knife that you can push through the skin, about 1 centimeter in diameter. So it's like a apple bore that you push there, a little bit sharper. And you create access in the abdominal cavity. However, everything in the abdominal cavity is collapsed. So you also bring in CO2 gas there to blow it all up, and you have space to look around. And you can bring down tools there. And during surgery, that can look like this. So if you ever have minimal invasive surgery, laparoscopy with cameras or the robot, they use basically trocars like this to bring in the robot or whatever, the camera and all the tools that are needed for surgery there. And 3 or 4 ports are usually sufficient for the whole thing. But a little bit less invasive is the use of endoscope. And we have 2 types of endoscopes. One is rigid, you cannot move it around. little bit bigger, and you can use high-end optics there. So the image quality is very high. But we also have flexible scopes. Flexible scopes have usually a chip on the tip, a very high-end sensitive camera. They go up nowadays to HD or 8K even. To create an image, and if you also bring in a light source, you can look around. And the light source is usually also located via fiber or whatever. You can bring down a lot of light and you look around. And these type of scopes are ideal to inspect, for example, the esophagus or the inside of the bladder or any cavity where you don't need a knife, but you can use the normal entrances of the human body to get there. You can imagine how that works. Again, a little bit of idea how that works. So we have camera in the middle, we have light sources on the side and a work channel to bring down your tools. But one step back, OCT and ophthalmology. I'm not sure if you already had lectures from Johannes de Boer. So he probably showed already a lot on ophthalmology, because that's what he used to do a lot. Again, the headrest, I already explained it, and you can make beautiful images from the front and the back of the eye. And this is all data from Johannes, so I think he showed it as well. Maybe you also explained that it's possible actually to look at things like the Doppler signal from OCT data. He explained that. Beautiful. This is an example of actually how that looks like. I'm not sure if he already did that. But suddenly, besides just beautiful images, you're possible to analyze Doppler shifts basically in your OCT data, which are related to the moving red blood cells. Yeah, it's an old presentation, but these are the type of data sets that we use to make. And again, all these several layers are visible in a retinal OCT data set. And if you look at the Doppler shifts, you can build up what we call an angiography image, and you can suddenly show all these tiny blood vessels there and the whole network. And I guess the take-home message here is that besides making pretty images, on top of that, you can get what we call functional information by studying the interaction of light and tissue. In this case, looking at the Doppler shift. We also did different analysis back in the day where we looked at the vibration of the eye during an acquisition period of such a three-dimensional volume. Because what we saw is that instead of having this beautiful 3D smooth retinal layer, except if there's huge pathology, of course, but there is this vibration in there. And that was studied by one of our PhD students back in the day. And he showed that this was directly related to heartbeat, yeah, oh, it's up there, yeah. I was wondering heartbeat or breathing, but this is heartbeat. And so it gives you additional functional information on what's actually the physiological process over there. So things in ophthalmology, don't want to spend too much time on that. I'm not sure if Johannes already showed stuff on cardiology, because this is where we started to use this tiny catheter. Now in cardiology, we used OCT quite a bit for several reasons. Again, we used this system with this beautiful tiny catheter. But there were three reasons after a lot of consultation with clinicians. Okay, what is the clinical value of such a technology? One was what we call post-stent localization. One of the treatments, if you have an artery that is filled with either slushy, whatever, or a thrombus or a stenosis, really closure of an artery, what you can do is bring in a balloon, bring in a stent to open everything up. The stenting is done by an interventional cardiologist. And the whole idea is you bring in this little, what we call chicken wire, and you blow everything up, and everything opens up again. And I'll show an example later. Another one is what we call thrombus detection. That is when such a, what we call a vulnerable plaque, a plaque in the arteries ruptured and released lipid in the bloodstream. You get a thrombus, and thrombus detection was something that's quite important to visualize, because then you can treat it. If you know where it is, and you know the extension of it, you can do something about it. And then the plaque itself, I'm not sure if you can really see it. Maybe you can switch off the light. We can do it somewhere. No, that's all gone. All right. Okay. Yeah. Yes. Better. So within the OCT data set, if you make this lighthouse probe-based images, this within the tube, within the artery, you could see these kind of things. Which is a lipid pool with a very thin cap on top of it, and the thickness of the cap determines what kind of treatment the patient will get. You can imagine if it's too thin, there's a high likelihood of rupturing into the bloodstream, so you get all the issues. But the killer applications of, killer application is post-stent localization. That's a good point. What you see here, maybe the middle one is the best one to look at. We bring in this catheter, right? And it's in a tube, an artery. So it's a luminal cavity. We flush away the blood. So that's why we can look through it. It's empty. But in the middle, you can see this round structure. That's basically the probe itself. The probe itself has some mirrors and some optics there that gives a tiny reflection. So during the scanning, it creates a circle of that tiny reflection itself. That's what you see here. Not sure if you can see it. Then you see this bright spot here. Any idea? The bright spot there is a metal wire that you bring down first before we go in with the OCT catheter. We call it a guide wire. And the interventional cardiologist uses the guide wire to bring down any of his tools. You cannot bring down an endoscope into your arteries, right? That's really too small, and you create a lot of issues. But what you can bring down is a guide wire that you can see during X-ray imaging, so you know where you are. And usually they bring it down, they bring it somewhere downstream. In your femoral artery, for example, you go in here, and the bloodstream itself guides the wire to the heart. And then when you end up at the heart, you can steer it by twisting this wire a little bit to make sure it goes into the right artery. That's what they do, and they're super handy in doing that. That's the trick that they do. So this is the guide wire. This is metal, we cannot look through it, so that's why you have the shadow. And then this is the surrounding tissue of the artery. And you can see some layering in there. I'm not sure if that's really visible for you guys. Which is all these muscular layers of the artery and some endothelial cells. That's how the lumen is built up. You start with endothelial cells, and you have intima, which is a muscular layer, and extima, something like that. And that's a cross-related muscular layer there, so it's in a different direction, so it can squeeze and open up. But that's basically what you see here, and here you see also this thrombus, which is similar to this plug, but then the cap is ruptured, and the lip is released to the blood. And that's what you see there. Now here you see all these bright spots again, and that it has to be. I mean, did it answer your question? What you see? Are you? Yeah. Again, this is what you do in cardiology. You bring this chicken wire, usually it's a metal stem. And what you really want to know, this stent, when you deploy it with a balloon, that it really touches the side of the lumen of the tissue. Because if it's still floating around in the lumen of the vessel itself, it's basically an ideal ground again to build up a thrombus, because red blood cells can hit it, can attach to it. So you really want to make sure that it really is touching the side of the wall and really open it up completely. And OCT is an ideal tool to check that in 3D. And that's basically what you see here. Again, these are these cross-sectional images, and here you can see all the bright spots of the metal stem that is there, and it gives you a cross-sectional view. Did it really touch the wall of the artery? And of course, we do a pullback, so you can do that in 3D over the full length of the stem. And this, I like to tell this, but we did this, I would say 7-8 years ago. And we were quite proud of that we were able to achieve this, also the 3D visualization. But what you see maybe in this 3D visualization again, there is this movement artifact, breathing or heartbeat, but it's there. And what we developed back in the days was called a fully automatic straighten and stent segmentation tool. So it helps analyzing this movement artifact, straighten it out so it wouldn't be an issue anymore. And it segmented out the stent, the metal stent, replaced it back into the data set, and really gave you an opportunity to visualize this and see if there was what we call a mal position or a correct position of the stent. And we used to do that. We were very proud of that in 7 minutes. And we did all that research to get there. And a week after we achieved that, there was this Japanese group that did it in 3 seconds. Because they were just better at it, I guess. Yeah, we were still proud of that. Yeah, like I said, right, we could do these type of things. Also, back in the days, we studied what we call the content of what's in there in this vessel wall. In case of a plug, for example, if there's a tunnelable plug, you actually want to know what the content is of that lipid pool, and it has clinical or treatment implications. I don't fully know anymore what it was because I'm out of cardiology for a while now, but it had clinical implication treatment. And based on work developed by Dirk before, we were able to look at what we call the attenuation coefficient. You guys still remember what it is? Has been explained? I see all the face there. And looking at the attenuation coefficient of all these different tissue components, you suddenly have a tool that helps you quantifying the content of something that's in there. You can compare it to, for example, the lipids that we know, or maybe calcifications, which have which probably have a different attenuation coefficient. And that's something that we already did back in the days. I remember there were some issues with this type of data, but people have taken that work up and did it over a full circumferential scan to really look at this attenuation coefficient, creating algorithms that tells you, okay, it's the attenuation map. And in this attenuation map, you have 2 types of tissue. If you threshold that attenuation coefficient somewhere, it probably tells you, okay, there's lipid and there's calcification there, something like that. That's what they did. They compared that to histology and really could do a one-to-one comparison on, okay, is it what we study in our ends? Is that completely right? So that's stuff that is still be going on in cardiology, but then in very large studies, patients that come in the hospital here or at the AMC location, actually, they all undergo an OCT or what we call similar trick, but then with echo intravascular ultrasound pullback. And within those studies, they try to find correct cutoff values for example, attenuation coefficient or different things that they do. So that was some what I call benign applications, ophthalmology and cardiology. Now we go back to more the malignant side of medicine, and that's oncology. That's where we do a lot of work. And I'm going to show you some examples again of OCT in urology. And I showed you already this idea on applying that in the kidney. I will come back to that later. But first, I want to show you some examples of how we use the same trick as we do in the cardiovascular system, but then in diagnosing urothelial carcinoma. Oh, no question. Urothelial carcinoma is cancer of the bladder and the upper tract. The upper tract is the tube from the kidney to the bladder to bring down the urine. And in this inner lining of these cavities, cancer can occur in the epithelial cells. Epithelial cells are really the inner lining, like the carpet of these organs. And within this organ, the tube from the kidney into the bladder. All right, that's clear. Okay. And what we usually do there, now the movie doesn't want to play, but what you see here maybe is a little tool. This is an endoscopic image of this tract. So you can go in with an endoscope into the bladder, to the urethra, into the bladder, in the ureter, and study this whole inner lumen. And when you see there a lesion growing because a patient came in, beat some blood or whatever, you want to study that, you can take a biopsy. And what you would have seen here is tiny tool that goes in there and takes a piece of tissue. with what we call a biopsy forceps. And this biopsy tool is under a millimeter. It has to go through the work channel again. But the pieces of tissue that you get out are even smaller. And the smaller the piece of tissue, the harder it is for a pathologist to give you an answer on what actually is going on there. Because it's harder to process, it's harder to create those microscopic slices. And with this tool, you basically yank it out, and all these cells are becoming mingled, and it's just hard to give you an answer on that. So the question was out of the clinic, can we use OCT that you use in cardiology to study those thrombi or these plaques? Also here in a similar tubular system, similar dimensions, and tell us something about what's going on there. What do we see? And can we relate that to what actually is going on there based on histology, histopathology? Of course, again, we use the workhorse. Well, this one works. And here you can see how we bring down this catheter into a patient in the tube. And if you look carefully, you already see some kind of weird structures there in the wall. Some cauliflower structures that are flowing there. And we can bring in the OCT catheter, it starts to rotate. And again, this other movie will not play. Yeah, it says codec not available. But we can create a three-dimensional pullback of that system there, of the tissue under study. And what you get is this, similar to a coronary artery. Of course, the whole scanning mechanism is the same. And we build up again a scan about 5.2 centimeters. We have 540 images over this range. So every 100 micrometers, there's an image. And we can study the tissue like this. But if you encounter a lesion that is suspected for cancer, it might look like that. When you see that up there, it is tiny, tiny growth into the lumen. But what you can also see there, and let me point it out with the mouse, I'm not sure if you can see it there. There's this layer here where the arrow is pointing. And this layer is continuous. And from a clinical point of view, this is very important. Because if you have a lesion there that did not yet grow into the tissue itself, this layer is still continuous there, which we call the basal membrane. And that's a layer that's in between the epithelial cells and the muscle cells. And when the lesion is still just present there in the epithelial cells, it did not breach yet through. It's not what we call an invasive tumor, but it is a non-invasive, non-muscle invasive lesion. Of course, you can also have a situation like that, where you do have, or you don't anymore see this continuous layer, and there's suspicion of ingrowth into this muscular layer. And then suddenly you have an invasive layer. And basically the two differences there is if you have a non-invasive lesion, you can just burn it away, this lesion, remove it, and usually as a patient, you're done. We still ask you to come back about 6 months after that for a follow-up. But after this, you're usually done. But when it's invasive and it grew into this muscular layer, then this tumor has been shown into the, or introduced into the blood system, because the muscular layer is very high perfused. There's a lot of blood moving around there. And then the likelihood of metastasis is very high. And you can imagine that treatment then changes completely. And so instead of burning away these tiny lesions with, for example, a laser fiber, we have to take out the whole system, and the kidney is removed, this tube is removed, and a part of the bladder is removed. It's a very, very invasive surgery with a lot of comorbidities. So being able to look at the difference of these two has real clinical implications. And suddenly we were able to do that with a OCT system like that. Now, I said before, we used to get in with this tiny forceps. And the problem with that is if you do that, again, you have this waiting line for the pathologist before you have an answer. But also taking the tissue is quite dangerous. You yank it out, you cut it out, and you can create holes into this tube and create tumor spillage, cell spillage, and that kind of stuff you don't want. So here, actually, OCT actually has a really big benefit of having a minimal invasive diagnosis on ingrowth. Another thing what we can do, similar as in the arteries or any other work, is looking at this attenuation coefficient within a lesion. And why is that important? Because if we look at how this buildup of a tumor goes, usually it goes from a not so aggressive to a very aggressive tumor. And again, a not so aggressive tumor and not so aggressive tumor cells have different clinical implications compared to highly aggressive tumor cells. The difference between the two in the development of these tumor cells is that when it starts to develop the cancer, a lot of energy is needed. If it's a very highly aggressive cellular environment, you need a lot of mitochondria in these cells. You need, and as a result, due to this, what we call aggressive development, you have a lot more cellular compartments and nuclei and stuff like that. You might have actually multiple nuclei per cell because it's dividing like crazy. And you can imagine if that's the case, that light scattering in a very aggressive cell group is different compared to a low aggressive cell group, where things are organized and structured more normal compared to the normal situation. So looking at the attenuation coefficient in low grade or low aggressive compared to high grade, highly aggressive lesions showed us that we can actually say something about it. So here you have the attenuation coefficient versus the grade. And we were able, and it was in 26 patients back in the days, to really determine, okay, we have a tool now that not only can look based on studying the images on the ingrowth, but that says also something about how aggressive the lesions are. And again, highly aggressive cancer, even if it's not invasive, but highly aggressive, has a different treatment. Usually you get a lot of chemo as well. We can still burn it away, but we have to take more aggressive measures. And if it's a really low-grade non-invasive lesion, again, burning it away and you're done. How long am I going on now? Do we take a break, Dirk, or do we continue? Huh? Is there a break? Okay, just give me a heads up when it is. Anywho, the OCT is one of the tools that's out there right now, that's in the guidelines as the promising tool to assist with diagnosing this typical urothelial cancer in the upper tract. And that's because of all the work we did back in the days, and we are quite proud of it. And you can imagine that this might actually have a clinical impact. If we are able to do this in a large patient group and show the same results as we showed in our pilot study, we are actually really in business. And because of this, we have discussions now with the reimbursement about reimbursement of a technology like this, even if it's still in the study. This again is a summation of all this, everything I just said. So we leave it with that. And the tool itself is actually also ideal to be integrated in another imaging technology. For example, X-ray imaging, CT imaging. CT is basically a three-dimensional X-ray that covers a larger area of the human body. By rotation, we create a three-dimensional. And we use that type of imaging to at least know where the scope is, of course. If you go in there with a small endoscope, you want to know where that scope exactly is. But also the OCT probe that you bring in there. And what you see here is this purple line of the OCT probe in this urothelial system within the kidney. And it also allows us now to really integrate a CT segmentational data set with the OCT data set in orange here. And that gives us a full picture of what's going on, and not only on the microscopic scale with OCT, but also on the microscopic scale with technology like CT or MRI. And this is an example of that. All right. So already in the beginning, I showed you the application, the possible application in the kidney. And you asked the question, okay, patient on the side, how does it look like? And we already go into the kidney to take a biopsy with a needle, and we already go there to treat it with a needle. So now if we have a technology that's fast, or actually real time, and allows us to do diagnosis on it. You have this, what we call a one-stop shop. You come in as a patient, and by the end of the day, you're a treated patient. We started this work also a long time ago, where we studied a kidney, and this is a full tumorous kidney. So in this kidney, it was clear cancer, and not just part of the kidney, but the whole kidney. But it was ideal for us to study, okay, what are actually the differences that you can expect already ex vivo, where we put a little bit of tissue under the OCT system, take that tissue, process it in microscopic slides, and give it to the pathologist and compare these type of data sets. And this is with the system way back in the days. And we were already able to create these type of comparable images. And again, we could study ex vivo the attenuation coefficient, and it showed there was a difference between normal and tumor. Well, clearly, a normal kidney, well perfused, is red, and the tumor is white. You can see that by eye, but at least it showed that, okay, this tool worked, and according to what we expected. And it gave us reason to do this in vivo pilot. And again, this was back in the days. This was a approach that was developed as interface with a OCT system that we had there on the shelf. We connected both, and during laparoscopic surgery, the surgeon would take our tiny OCT probe, although this one was bigger than the one that we use in cardiology, about double the size. Take it with one of the laparoscopic tools, the grasper, and maneuver it towards the kidney tumor. And that's something you see here. You can see here the kidney, and you don't really see that there is a tumor underneath there. And place it on the tumor, and we can start to do imaging. It was really cool. And here you think, okay, we visualize the whole kidney. That's not the case. This is just a tiny part of the kidney, about 5 millimeters. Due to our acquisition strategy that we have, it curves off on the side, but we were at least able to study the tissue and again analyze attenuation coefficient. And we showed there was a clear difference again between normal, of course, a tumor, but also between benign cancer and malignant cancer. And that was nice. And why is that so nice? That's because nowadays we have a huge increase in kidney cancer, not because it's more prevalent, but because patients are actually diagnosed by accident due to a scan that they get, for example, for the thorax. There's a little bit of kidney in that scan. The radiologist looks at it and says, hey, besides the problems in your chest, I also see this lesion in the kidney. And all those patients are referred to urology. That's good, right? Because if you see an early lesion, treatment is way better and the outcome is way better. But the increase in patients has been dramatic. And these early tiny lesions, as we call it, under 3 centimeters, 30% of them are benign and don't need any treatment whatsoever. And I'm pretty sure we have them, all of us have usually a tiny benign lesion there. It happens, they go away, they come back. It happens. But you have to know what it is. So you either take a biopsy, like I said, or you have a tool like OCT that you can bring in there and differentiate between benign and malignant tissue, and you have your answer right away. Again, we were able to do that, but you want to do it during a diagnostic procedure in the needle. And I'm going to show you a movie now how we do that with patients. It's not, you only see a little bit of the patient, but it gives you an idea how this works. I hope this movie works. It works. So, needle-based OCT in the kidney. This is an actual patient. And if we bring in a needle here to anesthetize the tissue. So there is not too much pain right there from the needle itself. Then we create a hole, what we call a trocar needle, but then tiny. A metal needle that you can bring down there into the tumor. And we take out this core, and suddenly there is a needle within the lesion of the patient. Again, the patient on inside. So we can bring in this OCT probe. We retract the metal trocar needle. We retract it because we cannot look through metal. But the OCT probe is still in the tumor, really in the mass of the tumor. And we start running it. And we get a data set like that. You can see the beautiful structure there, and suddenly it's noisy. So my question is, do you have any idea where the diagnostic information is? Is that in this beautiful structure or in the noisy part of the data set? Any idea? We also take, by the way, a regular biopsy from exactly the same location. That's here the biopsy killing. Gives you these type of tissue slides that are brought to the pathologist for further analysis. The thing is, again, when a tumor starts to develop, you lose coherence with the environment and you lose integrity with the environment. So all the structural information and architecture that used to be there is gone and becomes a random environment. All these cells growing, basically the same cells, but the structure is really a random kind of structure that grows there. And that's the noisy part of our data set. So that's where we actually are in the vital tumor environment, as we call it. The trick with taking a normal biopsy is that an interventional radiologist does that, right? The patient again is on its side. You have to go through the skin and puncture this tumor, but you cannot puncture the tumor head on, which would be easy, of course, because then you will hit it. But the problem usually with those tumors is they have a necrotic core. So you enter that, you suck in some tissue, but most of the time those are dead cells. And you give that to the pathologist, and he has no idea what he's looking at. He says, yeah, I only saw dead cells. I have no idea if it's cancer and what type of cancer, or if it's benign. So the idea is that you hit a tumor or a lesion on the side. And that's where you have the vital tumor cells. And you don't want to hit it in the normal tissue, you don't want to hit it in the necrotic core, really on the side, which makes it quite hard also for the interventional radiologist to give the pathologist a diagnostic piece of tissue. And we have very good ones here at the Amsterdam UMC, but I'm convinced the good ones are everywhere. But we have a hit rate of about 70–80%. Not great. No. Yeah. And I give you some examples later on what it is. But here you see a lot of structure, all these layering going on, some openings there, but suddenly you're there. And this is when you're in the tumor. Ah, there you go. So these are the three most important classes that we want to differentiate. One is the benign version of oncocytoma. This is the most common benign tumor that's there. And you see this island structure that's there around, again, this needle-based probe. We have the renal cell carcinoma, that's the malignant invasive version with a noisy structure around it. And perirenal fat, that's the fat that grows around an organ. Everybody has that. Some people more than others, but everybody has perirenal fat. And you don't want these tumor cells to be invasive in the perirenal fat. And the perirenal fat has this classical honeycomb structure that we can see very well in OCT. And we hope then, of course, that we don't have these malignant clusters in there. So these three types of tissue we want to differentiate to come up with the diagnosis. And again, if it's an oncocytoma, we don't do anything. If it's an RCC, you can go for surgery or for a minimal invasive approach with needles. And if there's nothing going on in the perirenal fat, you're lucky because then this diagnosis still holds. If there's clusters of cells in the perirenal fat, then again, treatment changes. Chemotherapy comes into play, immunotherapy, radiation therapy. Yeah, and that's solid tumor. That's what we call solid tumor. Sorry? Well, in the study, we did that because we want to compare it. But we hope to prove, we did it now in 160, 170 patients that already showed us quite good results, but we have to extend that study. And we hope that the technology like OCT one day will replace them, the invasive biopsy procedure. Do we get rid of biopsies altogether? No, because even now, if you are unsure of what you see you still want to take a biopsy. Oh, yeah, solid tumor. Yes. Yeah. Yeah, again, some examples of how we do that. Of course, we do it in 3D. We take this pool back. If the tumor size is long enough, you have a full tumor in there. But yeah. And again, this gives you an example where we can study the attenuation coefficient. We can do that nowadays over the full rotation, over the full pullback. You get a three-dimensional attenuation map of your tissue under study, and it tells you something again about the grade. So even if you're in this noisy part, you can again have less aggressive and highly aggressive cells there. And both have again a different clinical outcome. So having this knowledge is key, and we can analyze this attenuation coefficient. We can already tell the difference between benign and malignant. And that was in 160, 170 patients. We're quite happy there, but now it's important for us that within the malignant group, that we were able to make a differentiation, and we are not there yet. But using a tool like the attenuation coefficient might actually help us a lot again there to give us this answer. Box plots on what I just told you. Now we move to gynecology. I have no idea about the time. Just at least tell me when it is time. Oh, okay, good. Things get a little bit more graphical here, so I warned you a little bit. But after discussions we had with the gynecologists at the Dutch Cancer Institute, so they're oncological gynecologists, and not the gynecologists that help delivering babies and stuff. This is a little bit more on the dark side of being a gynecologist. But they approached us with the question on vulva carcinoma. Vulvar carcinoma is a disease that's getting more and more prevalent because it's induced by the human papillomavirus. And the human papillomavirus itself is the deadliest SOA out there because a large part of patients with HPV can develop this into a cancer. The most common, of course, is uterus, cancer of the uterus, uterine cancer, and vulva carcinoma, which is basically the same tissue, but then on the outside of the system. So this is a combination of gynecology and dermatology. The whole problem is because it's human papillomavirus induced, is that it will come back. Even after you treated the whole thing, it will come back because the virus will always be there. It's latently active in the spinal fluid. It will always come back. And the patients that have this type of tumor sometimes had a treatment and a diagnostic biopsy for the 30th time in their life, which is extremely invasive and painful, psychologically a huge burden. You can imagine if you have a tool now like OCT that you can bring in there that takes a scan of the tissue and tells you what's going on there. And you don't have to do anything today, like for removing skin or harvesting more tissue, because nothing changed compared to last time. Right, they have this tool. It would be a huge benefit for these patients. Again, OCT of the skin, beautiful. We can do this fingerprint, awesome stuff. All the layers of, for example, in your fingerprint. This is something actually that's being used in the research now for fingerprint detection, because you have the same fingerprint in the deeper layers of the skin. So you have people that try to remove the fingerprints by, whatever they do, sanding it down or using a chemical. Yet that fingerprint is also present in deep layers. And we have people in our group that study that. But back to a more graphical situation I warned you about. This vulvar intraepithelial neoplasia, which is the precursor, again, of a full-blown carcinoma there. So it's not yet invasive, but it's those already aggressive cells. They can grow all over the vulva. Again, human papillomavirus induced. You don't know where it will appear and how, but it will appear and it will always come back. Um, so what basically happens is, in order to diagnose, you take a biopsy. That's not nice. They use really something again like a trocar to remove tissue there, stents it out, pushing it out. You have a nice piece of tissue, bring it to the pathologist and study it. And after you know what it is, you can do a local excision, cut it out with a knife, laser evaporation, burn it away with a laser, or use medication if it's needed. But again, all these treatment options are very invasive, not always needed, but the diagnosis in itself is already very, very invasive and mutilating, basically. You can imagine if you have this biopsy taken, and we're not talking about a tiny 1 millimeter core, we're talking about 7-8 millimeter cores taken out of this tissue, and you have that done for the 30th time in your life. That is not a great idea. So here's an example of a suspected place. These are the tools that they use to take a biopsy. And again, compared to other epithelial cancers as well. What is important is looking at if there's normal tissue, if it's already a little bit active, hyperplastic, so a little thickening of the layer, but still did not breach through the basal membrane. Then you have intraepithelial neoplasia. It's really thickening of the layer, more aggressive cells, still no breach through that layer. And then the full-blown carcinoma, where you have this complete breach through the system. And again, then treatment again changes dramatically. So the question is, can we determine this stage? Because before all this, treatment is relatively okay. After this, again, chemotherapy and all that, what you want. So we started this study using OCT, and we looked at the skin or the skin of the vulva and studied it with OCT and looked at parameters as thickness of these layers, because the thickness is really an indicator of how far the process is, ingrowth, and attenuation coefficient again. And we were able to take these type of images. And yeah, this is a little bit on the explanation between normal and malignant cells. Like I said, you can expect in the case of these cells becoming more malignant, more aggressive, that light scattering will be different that we pick up with the OCT. And we could analyze the attenuation coefficient again within layers of interest. And again, we have a high interest in this thickness layer, this dark gray layer, which is 3%. If you look at the A line there and study the attenuation coefficient, and what you see here in the first 16 patients that we did is first, compared to normal skin, this intraepithelial layer is way thicker as expected, of course, but the attenuation coefficient is also much higher. And again, this is a direct tool to study this, to study if you can use a tool like OCT in the diagnosis of this disease, and more important, in the follow-up of the disease after the first diagnosis. Again, to see if anything changed compared to the moment before, without having to take this invasive biopsy. And this is really where OCT is, again, a powerful tool to differentiate tissue types. So that's an example in gynecology. I need a little coffee break and water break, if that's okay with you guys. And then we move on a little bit on how we use things in surgery. So also the guys online, we take a 5-minute break, 5 minutes. 10 minutes. Cool. Then we continue. All right. Let's show you at least a maximum of 2 more examples. And bear with me. But at least OCT is used again in a different fashion again. And this is really in open surgery. Open surgery is becoming less and less common because we can do all these minimal invasive things. And we have the laparoscopic approach, the robot, even single port robot. So you go through the belly button with a little bit bigger tube and you deploy everything in the abdomen. Yet we still also have open surgery because some surgeries are so invasive and needed to be done in such a way that you cannot do that laparoscopically. And usually those type of surgeries have something to do with transplantations. And they're not straightforward or kind of straightforward kidney transplantation, but more, for example, piece of muscular tissue transplantation. And we call that a free flap transplantation, where you can, for example, take a piece of tissue out of the femoralis environment and move it up to create a new breast. That's something that the plastic surgeon does a lot. After, for example, a breast surgery due to breast cancer, and you want to create a livable new environment. But it also happens when we, for example, do resection of the esophagus. We have this full open approach. It can be done laparoscopically, but we still also have this full open approach where the whole esophagus is removed. Patients that are suspected for esophageal cancer first usually undergo radiation therapy and chemotherapy before they get surgery. It's a little bit the other way around compared to most surgeries in oncology. But it was found out that this really dramatically increased the survival of the patient. So if you start killing all the tissue right away and then surgically remove whatever is dead there, those patients have a much better chance of survival. But you can imagine if you bombard, oh, sorry, yes.
Which type of cancer was that?
Esophageal cancer. That's the whole word, but it's the slugdarm. The type of cancer, I mean, that's the anatomical location, but yeah, of course, you have several types locally that it could be. But on average, so you want to first bombard it with radiation and with chemotherapy. But you can also imagine that everything there in that environment has been, treated in such a way that's dead. And you want to remove this dead tissue surgically. And what we can do is create a new system. And you take the stomach and you pull the stomach all the way up to a piece high in the throat, and you reconnect the stomach there. And you can still eat, not as much as before, but you have a system that works. Sorry? Oh, a system that works, at least for eating. Yeah, that's crazy. Can you imagine? But here's the kicker. If you do that surgery and you're done, and you close up the patient, in 20% of cases, things go bad, which means that you get leakage. And that is because the tissue is actually not vital enough anymore to start a new working perfusion, well-perfused tissue. Basically, what you want to do is all these tiny blood vessels from one side of the stomach and the other side up here in your throat from your esophagus, you want to reconnect it. But you can imagine if that has been radiated and it had chemo, that even that was on the edge of the treatment area, it could still be harmed in such a way that it will never go back. So the idea was, can we, before we make this, what we call, it's called an anastomosis, the surgical connection of two types of tissue, can we predict beforehand if that tissue is vital? With other words, does blood get to that cutting edge where you want to create this anastomosis? And we've been studying that with several optical techniques. Again, here you can see graphical representation of the surgeries. Yeah, what else could be? Here's the cancer is after all the treatments, you take out this whole thing and you pull it back there. Those surgeries are intense. They take about 10, 12 hours. Patient is halfway during surgery. The patient is moved completely from back to belly with all the wires attached there, all the instruments in there, and moved back again to the back to actually perform this surgery. But it works. However, again, in 20% of the cases, you have leakage due to necrosis. You don't want that. This necrosis again could happen because of several reasons, right? There's a lack of oxygen and nutrients that enters the tissue because oxygen and nutrients need to be delivered there by the red blood cells and white blood cells. But if everything is damaged there and they don't get there, the tissue dies. As a result, again, you get tissue necrosis and it's high morbidity. And again, if leakage occurs with these patients, you already closed them up, everything is closed. Yeah, they suffer dramatically, and a large part of them do die in pain. So that's not a great situation to be in. And what type of? The leakage. It usually happens 24 to 48 hours after surgery. But the patient already closed everything, then you don't really want to go back there. If you have to, you have to, but it's usually too late. And we're talking about when the patient shows symptoms of the pain and the agony and the fever that comes with it. And usually you are already too late then. And again, so this need for intraoperative perfusion monitoring is important. Perfusion has its own unit, milliliter per minute per gram tissue. It's a weird unit, but that's basically what it is. So if you look at the tissue, you want to know how much blood moved in this three-dimensional volume over a time frame. And something you basically really can show with technologies like OCT. There are more kits on the block that can do that, but OCT is really a nice candidate. We had 4 optical technologies during surgery to test this. You can imagine that this surgery is already quite crazy with everything that's going on there. And on top of that, we had 4 big systems in the OR measured on the patient, used on the patient sequentially after each other to see which one of the 4 is actually best to continue in the future. So we had OCT, we had side stream dark field microscopy. I'm not sure if Dirk already showed something on that. He might do later on. Laser speckle contrast imaging, that's a large area visualization tool of perfusion, fluorescence imaging, where you inject a fluorescent dye and you look at the camera. If it moves along, you take a picture of that. Nonetheless, we are right now or today interested in OCT. And again, this is a picture of the surgery. It's open surgery, it's open. This piece of the tissue is taken out of the human body, placed on the side on a little tray. So we can do the imaging on this newly formed tissue. What you have to understand is you take the stomach and pull it up, right, to make this connection. But in order to do that, you have to kill 50% of the blood supply of the stomach. You have to take it because those blood vessels will not travel up. You have this other branch on the other side of the stomach that moves nicely along with this pull-up procedure, but one part you don't. So that's another reason why perfusion could be hampered in this beautiful solution you want to create. Now we also have what we call a watershed. A watershed is something in the tissue that's right there, where one type of perfusion is separate from the other type of perfusion. It could be just two different arterial branches that are not connected. And usually in the esophagus, there is one somewhere located there. And during our measurement, that's a beautiful location to be aware of where we actually are in tissue. And the surgeon created this indication of where he expected it to be. So what we did with OCT, we created measurements of the tissue at these 4 locations to determine which part was best or worst perfused after surgery. And we created these type of data sets, 3D with OCT, and you see the dark holes, which are not the blood vessels, those are lymph vessels, filled with clear fluids. That's why they're dark, appear dark in the middle. And in order to visualize the blood vessels, we had a different approach. The lymph vessels we could segment out easily. That's here in green. It's maybe hard to see, but this is the segmentation of all those dark holes that go through the 3D data set. It gives you a visualization of the lymph system. Ooh, let me check now. Yes. And we created again what we call a perfusion scan with OCT, looking at, you could do that, for example, using a Doppler shift approach. But in this case, we did similar to a speckle camera. We looked at changes in speckle behavior within the OCT data set. That's something Dirk has been working on for quite a while. And it helps us really study tiny microvessels in an environment like this much faster than we regularly did with the Doppler approach. And you get these type of images. And the micro circulation, all these tiny blood vessels are visualized here, segment out based on the speckle change. And what you see here in red is this perfusion of the tissue. It does not tell us yet if it's well perfused or not, but at least we are able to do it now with OCT. And it is again some kind of an optical biopsy of the tissue that gives you right away an answer on the state of the tissue. Cannot show you results yet on a full study. What I know by now is that it actually works quite well. However, in the first population we had you always start with the pilot. I think we had 10 or 20 patients. And again, the leakage only occurs in 20% of that group. And so far we have, by some luck, I think only 1 leakage patient. So it's hard to tell a difference. Which means that maybe in the next study we do, we have like 5 or 6. Because statistics, you know. In the end, they average out somehow. Okay, last example. Then we're really done. Again, a question by plastic surgeons. Plastic surgeons are also hand surgeons. That's what they do. So they can give you the most beautiful skin again, everything in well proportioned, but they also can perform surgery on your hand. Why is that? Because plastic surgeons, usually of all the surgeons, have the best motoric skills. And they can really reconnect tissue in the most precise way. To give you an indication, if they have to make an anastomosis in plastic surgery, they practice with cooked spaghetti to make sure that you are able, as a plastic surgeons, to stitch the end faces of cooked spaghetti together. Because you have to be able to reconnect all those tiny vessels. They have high-end motoric skills, and therefore they also perform surgery on the hand, or all these type of tiny bone structures that need a delicate change of the situation. Now, one of the problems that occur a lot in plastic surgery or in patients that need to go to a plastic hand surgeon is rheumatoid arthritis. We all heard of it. It's a huge problem. And rheumatoid arthritis is inflammation of the joints in the hand. And the most common location of rheumatoid arthritis is in the thumb, on the base of the thumb. And we call that the CMC1 joint. And then it's right there. And it creates inflammation. The inflammation in turn creates degradation of the cartilage. That's the soft bone structure that makes sure that everything moves nicely around without pain. You get this whole thing that creates trouble and really eats away the soft tissue structure. And it's progressive. It gets worse and worse. You get pain in more joints in the knees. Well, it's horrible. But if you're there early enough, you have treatments. But understanding how early the disease is, you need again a tool to visualize it. Hey, boldly gone when no one's ever gone before. This is with a hand. So the first time we started this research up, I worked together with this surgeon in training, and he walked around through the hallways of the hospital with cut off limbs, which was ridiculous. But in any case, he walked around in like a plastic bag. It was okay, but kind of sticky. But the beauty of hand surgery is that you can perform that surgery without blood being there present. So a cut-off limb is a good representation of a real situation. And if you have a limb of somebody that's old enough, then there's arthritis. So it's also an age-related disease. In regular hand surgery, they empty out your arm of blood. So they have it really looks like a inner tube of a bike tire that they put around the arm, like super tight rubber glove, basically. They roll it out, they roll over it, and it squeezes out all the blood of the arm. They create a blockage, so you don't feel any pain. Well, you don't feel anything anymore in that arm. The blood is gone, and you're still there awake. But it's the weirdest sensation for a patient to have this link there that's not there anymore for you, at least to be aware of it, because it's really, really gone feeling wise. But as a result, you can operate and do surgery there without blood being present, and that allows us to do nice stuff. Anywho, the question was again, can we see or visualize the state of the cartilage? Of course, we said yes, but we first showed it in goat. In goat, you say, yeah, like actual goat. Back in the days, we still had like fields in here in the middle of the area, the tiny little goats, adorable creatures. We killed 16 of them. I'm very sorry of that. Things are different. We don't do that. We don't do that anymore. Large animal research is forbidden now, almost forbidden. We need to have a very, very, very good reason. It's easier to do something on humans than on animals, because humans can say no. An animal, that's very hard. Well, but we did it in goats anyway, and we induced a cartilage issue there, basically, and then showed that yes, indeed, it was Steve. You can very well see it. And here you have normal cartilage, and suddenly you have this pit here, and here's normal again. Well, histology showed the same thing, of course. When I wonder about this research, and I show it now, but sometimes I wonder, why did we do this? Because we knew what we were going to see. We did it anyway. We killed 16 goats. Stupid. Again, we will not do that again. Huh? Yeah, so sorry for that. Again, being an animal here at the VUMC is a cruel situation to be in.
I mean, to be fair, you killed 16. We have farmers that kill thousands a day, and they're not being.
Exactly. At least those are eaten. Usually they are used for food. Those are just burned off. Again,
Those were used for medical intelligence.
I'm still not too sure about that. Again, it really confirmed what we expected. If that is enough for you, it's always nice to have positive confirmation. And we published it. And you know how they do this in humans? So this surgical table is beautiful. So that arm is there, and so they have this tool that grips the thumb, and then the plastic surgeon pulls on the arm, and you don't feel anything, but because it's everything, and you create a gap of a centimeter there. It's possible. You don't do it right now, It's not good for you, but you can do that. You have a gap, and when you have a gap, you can bring in a tool. That's where we come in. And so we took a transparent needle trocar basically and squeeze it in there exactly in that position of the base of the thumb. We could leave this needle there because it's transparent. That helps a lot. It's not metal. And then created imaging, and that's what you see here. So the OCT probe goes in there, and you see the data set appearing up there. It's not completely registered with each other, but at least it shows that here you see the normal appearing cartilage. It's just this beautiful layer on top of the bone, and here it is damaged. Now the first question is, was it damaged before, or did we damage it with the probe? I can't tell you. I have no clue. But we did now a larger group, and it really shows that it shows damaged cartilage. During that imaging, we also take a three-dimensional CT scan to really show the location of the probe compared to the bone. And again, on the bone CT scan, you only see the bone, you can't see the cartilage. So it really fits neatly together, those two data sets. Yeah, so of course we do this in 3D, but here you can see how it fits together on the CT scan. This is a 4-second CT scan. We segment out the edge of the bone there, and we were able to fit the OCT data set exactly on the CT scan. Histology again confirmed it. So it's much nicer to do this in humans than in goats. Goats, yeah. Because and it gives us this beautiful tool that tells us the state of cartilage. So, are we going to do that in every arthritis suspected patient? No. You know why? Because they don't come to the hospital. They always come way too late. People have pain in their joints, and they think, things go well now. We'll see you next week. Next week, it still hurts, and they think, yeah, I'll get used to the pain. And then, of course, the pain never goes away, and it goes to another joint, and then you're too late, which is a problem. So, but that's more about awareness, and it's benign disease, it's not malignant. I understand. You don't die from arthritis. You just get a very, unpleasant life, a lot of pain. So maybe one day this really helps. Because and on top of that, so treatment right now is removal of joint, like all these tiny, you have to clean it out. You can shape it a little bit again, so everything moves around nicely again. But there's still no replacement for cartilage, and there are studies going on based in Delft University where they try to create new cells that they grow on top of it with an injection and stuff like that. It still doesn't work, but that's probably how it will go in the future, that you can regrow cartilage there, and hopefully improve the situation a little bit until somebody comes that changes the disease completely, of course, giving treatment way before we come in. That would be nice too. Yeah, so I'll end here. Because otherwise we will go really in circles. I show you quite a bit of what we do. Even online, guys, thanks for your attention. I'm not sure who's there online. Let me check. Oh boy. Yeah. Thanks again. Thank you, guys. Thanks. If you have any questions on stuff like this, email me. My email address is d.m.bruin@Amsterdam. If you ever want to see some tools like this in action at the OR, you're interested in that, just let me know. I can bring you there, and you have a nice day of all this kind of stuff. If you have the stomach for it. You're physics students, right? Beta gamma. No? Medical physics. Okay.
Biomedical technology and physics.
Hey, all right. It's the best kind there is. Yeah. No, I once had a theoretical physics students in the lab or in the OR that crashed and punctured his head on the table, on the OR table, and he was out. Really? And then we had to bring him from the theater to the Eerste Hulp, which is weird.